kudaro kugoli hapana kana shanduko iripo izvo zvinakatoti ivo nambuya vasha vemboenda kwapapa profeti vari kuita mazuva ma1 zvimwe ngabatsirikana.
Ndakanzwa kuti last week futi wakanga wamutakura ukamuendesa kune chembere yaino inoita zvokuprofita ukazobva naye futi ukaenda naye kumaprofita vave mumasango avo wadii waenda naye kuchipatara wambomira kufamba nzvimbo dzakangowanda wanda?
Ndikupa kuisa sekuti but imozviona sekuti munhu ane nhumbu ungotangisa kuti afari panguva shoma yangoita nhumbu. Ndangaona ini nambuya vasha kuti takabvumirana natete ava anodzete maibi tete Stella kuti munhu uyu ange aenda kuna profeti kana kuti kun'anga vembogadziriswa inyaya yespiritual hatigozivi kachakauraya baba vangu mazuva akapera ndodai vane mwana
mbomena izvozvo pangoitika chidukuma kutsvaga urwe tozviziva kuti pfari vanhu vanoti chivanhu kana kuti mweya yetsvina chichi but inda naye kuchipatara aone madoctors zvitori good on condition yaari.
Indozvati imamuteti kuna napapa zvakanaka ingadzoka togoenda naye kune vamaherbs vemidzi vaya vembounogadzirisa vanoziva vaya vedhira for 2.
Don't go that far muzukuru wangu. It's not good pamunhu akazvitakura necondition yaari unopedzisira wakuvadzisa mwana pamberi panobva wopedzisira warasikirwa nezvezvakawanda.
Kuti kudaro resekuru but vanhu vari kungotaura kuti pfari spiritual mweya unenge uripo.
Enda kumadoctors pfari chirwere chinotoda kurapiwa chinoda kurapiswawo ukaenda naye kuchipatara madoctors akaongorora vanoona zvakonzera izvozvo vorapa chinotorapiwawo chipari. Vanhu havazvizivi kuti pfari chirwere choda kurapiswa.
Kana madaro sekuru ndichaenda ndomboona kuti ndombondovhunzisisa kuti zviri noma here kumunhu ane nhumbu.
Aona wakutaura
shuwa here sekuru
ndo muzukuru wangu
shuwa.
Dear doctor, I'm a man aged 29. My wife is carrying our first baby. The pregnancy is 28 weeks old. The problem is that a few weeks ago she started having fits, but she didn't have this problem before. I've been seeking religious interventions because I believe it is a spiritual attack, but my uncle is saying it can be a medical problem. Is there any medical problem like this?
Preeclampsia is a very serious disease. It's a multi-system or multi-organ disorder that is unique to pregnancy, and it is associated with an elevated blood pressure in pregnancy and also other associated complications during the same pregnancy. The real etiology of the disorder has not been fully elucidated, but the current theories actually state that it is a placental disorder, whereby the placental vessels that are meant to extract the nutrients, the oxygen from the maternal circulation are disorderly in terms of their development, and that instead of being very low resistance, high vascular vessels, there's sometimes constriction or narrowing the same vessels, such that now the placenta isn't functioning well as it is meant to happen because of this shallow sort of invasion of the maternal vessels by the placenta vessels. The signs and symptoms are multifactorial, depending on which organ system is affected the most or is the first to be affected. So we know again that the patient may present in various forms. Some may present with cerebrovascular problems, some may present with renal problems, that is the kidneys, some may present with liver effects, some may even present with blood circulation disorders. So in those patients who present with cerebral or brain problems, some will present with fits. That is when we call it eclampsia. That is, the patient is actually having seizures because of this elevated blood pressure. Some of the patients may actually come with stroke even for the very first time whilst they are pregnant. Some patients may come having bled into the brain. Some patients may actually present with visual problems whereby they're not able to see well. There's blurring of vision. Sometimes they start to see these bright lights. Sometimes they can't even see at all. Sometimes they may present with hallucinations coming from this preeclampsia. Those patients sometimes who present maybe with the thoracic or chest problems may actually come with cough, shortness of breath because of an accumulation of fluid within their lungs, something that we call pulmonary edema. Some patients may actually present with some pain that is usually under their ribs in the area of the liver when there's been bleeding maybe into that space of the liver. Some patients may actually come for the very first time with renal failure that's manifesting as a form of preeclampsia. Some patients may actually come with circulatory disorders of their blood where they are not able to clot, something that we call thrombocytopenia. That means a reduction in clotting factors of their circulation. Some of these patients may actually not even present with any of these problems, but we find that when you do scans, you do surveillance of their babies, you actually find out that the baby is actually restricted in terms of growth. The baby is not picking up enough weight during the pregnancy. Sometimes there could be just rapid swelling of the body. We know that swelling and accumulation of fluid is part and parcel of pregnancy, but this one becomes very abnormal, where a woman starts gaining weight quite rapidly. They start swelling, they start coughing, they're not able to support their body and their weight. They're generally feeling very ill, they are feeling very, very, very weak. That may sometimes be a sign of preeclampsia. But however, for us to be able to make this diagnosis, we actually use a combination of some of these symptoms so that we could be able to come up to a differential diagnosis. So usually and generally, some patients may actually just present for the very first time with a finding of protein in their urine. A health worker or a nurse or a doctor is doing a routine check of the patient's urine, and then they find the substance called protein within their urine. And if it's actually significant levels, one could actually make a diagnosis of preeclampsia. And remember again that this diagnosis, we usually make it after 20 weeks of pregnancy in patients who are not previously hypertensive or previously not diagnosed as having hypertension. So it is important that the timing is actually put into context when a diagnosis of preeclampsia is being made. So in pregnancy, if we're talking about preeclampsia, we are talking about the blood pressure, which is 140/90 millimeters of mercury, measured at least 4 hours, at least more than 4 hours apart. So this is what we mean by an elevated blood pressure in pregnancy. So most of the patients usually, unfortunately, will not have known what their pre-pregnancy sort of blood pressure levels would have been. But generally, if we find someone who has blood pressure of 140/90, I'm sure you'd understand what we mean by 140/90. That means when someone takes your blood pressure, there are two numbers that they usually record. The top one is called the systolic blood pressure, the bottom is called the diastolic. So once the top one is more than 140 and the bottom one is greater than 90, 4 hours apart, we actually usually say this is elevated blood pressure in pregnancy. So anything above that is actually gestational hypertension. We call it gestational hypertension unless and until we find other signs and symptoms that I have actually spoken about, that we then transition to a diagnosis of preeclampsia. We know that in nulliparity, that if it is your first pregnancy or your first child, you're actually at a higher risk of developing preeclampsia. We also know that if you're obese, you're actually at risk of having preeclampsia. We also know that if you've had it before, this disease in a previous pregnancy, you're at higher risk of having preeclampsia. We also know that if there has been a risk factor in your family, your mother has had it before or your sister has had it before, we are also at risk of getting it. Also know that if your interdelivery period is more than 10 years, we know that that patient is actually at risk of preeclampsia. We know that there are some comorbid conditions or chronic conditions, such as diabetes mellitus, whether is it the type 1 or the type 2, where someone is injecting insulin or where someone is actually taking the tablets, they're at risk. Someone who has had renal disease, disease of the kidneys, chronic disease of the kidneys, having dialysis, they get pregnant, they're at high risk. We know also that there are some endocrine disorders. Particularly, we are looking at rheumatoid arthritis, we're also looking at SLE, lupus. That those are some of the chronic condition that put someone at higher risk. We also know that if we are at the extremes of maternal age when you're having your baby, that means those who are elderly and those who are very young when they are having their pregnancies. We've seen women or girls under the age of 20 years. We've seen women above the age of 35 years. When they're giving birth, they're actually at higher risk of preeclampsia than the normal population. Let me also hasten also to say that being African is actually a high risk factor. Africans have actually been shown to be higher risk of this disease than Europeans or Caucasians. And we know that being poor or being in a poor, low economic sort of environment, like in the setting of our country, we are actually at a higher risk of developing preeclampsia. So these are placental abruptio or abruption. This is actually a premature separation of a normally sited placenta. Where a woman now has a placenta that prematurely separates. Remember, the placenta must separate from the uterus after the baby has come out and after most of the liquor and the fluid has come out. But this happens in utero. A woman is sitting at home, suddenly they feel this extreme excruciating pain and they may suddenly see themselves bleeding. This is quite a very, very serious emergency. We know that one of the causes is actually the underlying preeclampsia. So a woman may actually present like that, where they start to bleed from a prematurely separate placenta. So it is something that I want women, I think, to be cognizant of, that sometimes not all bleeding is normal, especially if it is bleeding that is abnormal before someone is delivered. Some may actually present with bleeding into their liver, into this subcapsular space of their liver. That means they start bleeding into the liver. That is a problem. Some present now with hematuria. Sometimes we see them presenting with passing blood in their urine because the clotting factors or the clotting mechanism has been disturbed by the preeclampsia. We see that kind of presentation sometimes. But the most difficult or the most painful one that I've had to see is a woman presenting with fits, seizures. It's very common that sometimes this disease is not well taken care of, is not managed early. They may actually end up with seizures, fitting for the very first time without any history of epilepsy. So if a woman starts to fit at any stage of their pregnancy, they should be able to report to a health facility so that a diagnosis of preeclampsia needs to be excluded. In any case, once a woman comes fitting in pregnancy, we assume that it is preeclampsia until proven otherwise. So it is very important that once that happens, they present early to the clinic. Some patients, like I've already said, they may actually end up with dead babies, what we call intrauterine fetal demise. A baby may actually die in utero. A woman doesn't know that they have preeclampsia, or they may suspect, or they may have other symptoms, but all of a sudden they feel that the baby is not kicking well. They may feel that the baby is no longer moving in intrauterine. That may actually be another presentation where a woman is coming to us and says, "Doctor, I can't feel my baby." And then when we measure the blood pressure, we test the urine, we actually find out that indeed she has had preeclampsia, and the baby unfortunately has demised in utero. Some babies may be born, but they have stillbirths, neonatal deaths. That means they die soon after they've been delivered because the intrauterine environment had become very hostile, had become very toxic to the survival of the baby. So that happens with preeclampsia. It may create a very hostile and toxic environment intrauterine that the baby may actually feel that it's actually safer outside than inside. That's how some of the patients may actually present. Besides causing these sort of catastrophic presentations in patients and severe and grave illnesses in our patients, they've also been shown that they can also lead to long-term effects both in the mother and also in the fetus. We know that women who have developed preeclampsia actually at risk of further cardiovascular diseases, heart failures. We know that they actually at risk now of developing diabetes mellitus even in future pregnancies. We know that some of them may actually carry on into chronic hypertension. That means once they've developed in pregnancy, that hypertension may never come down to normal levels even after delivery. They may actually continue now to go on treatment for the rest of their lives. Even in terms of the babies, we know that they're actually at risk again of cardiovascular syndrome. We know that they're actually at risk of endocrine symptoms. We know that they actually can develop obesity. We know that they have low IQs or low intelligence quotients because of the preeclampsia. So those babies actually are at risk of many other long-term complications that may actually not be present even at delivery when they're subsequently followed up. We know that this disease actually affects 2 to 5% of pregnant women. Hypertension of pregnancy. They actually affect 2 to 5% of women. 79,000 pregnant women. 79,000, not 79, not 79, 79,000 pregnant die annually throughout the world from this condition. 500,000 babies actually die from this condition annually. So you can imagine, or you can see the immense problems that this disease contributes towards maternal mortality and neonatal mortality. Is quite high and is quite significant. In my study that I've just done, I've actually found out that last year, in 2021, 11% of all our cesarean sections at Mpilo Center Hospital were due to this disease. 44.5% of these patients actually had preterm deliveries, that had deliveries before the time was due because of the disease. We know, I also shown that 18.1% of patients that had an operation at Mpilo Center in 2021 were actually under the age of 20 years. We also demonstrate that 18.4% of the patients were actually above the age of 35 years. So you can see that it's actually basically affecting young women, elderly women. Anyone is not spared from this preeclampsia. But those two groups, they actually seem to be quite high. Nulliparity, 55.3% of patients that were operated last year for this disease were actually having their first baby. Once a patient has been diagnosed with preeclampsia, they must then be in a place that is able to offer specialized care to the woman. And again, let me say that it depends really at the gestational age or at the age of or the duration of the pregnancy. So you'd see that a third of these women, they actually present with what we call preterm preeclampsia. That means that they actually present with preeclampsia before the baby is matured enough to be able to sustain their own life if they were to be delivered on that particular day. So again, the management will depend on how the patient is presenting, the gestational age of the patient, the neonatal facilities that are present at the place at which the diagnosis is actually made, and whether this is preterm or term preeclampsia. So in terms of preterm preeclampsia, if the woman is stable, it is just, let's say it is just the hypertension that is a problem, but the proteinuria is not set in, the maternal symptoms are not set in, the baby is growing well. These are the women sometimes who would come to our hospitals. We put them on some antihypertensives. We lower the BPs. We ask them to continue with their pregnancy until they are 37 weeks, and then we can plan a delivery. But if the disease is presenting in the severe form, those are the ones that want to admit and plan a delivery. I really want to emphasize this point to say preeclampsia is not cured until the woman has been delivered. You may be able to put a woman on hypertensive tablets and the BPs go down. You may be able to exclude renal involvement, liver involvement, but as long as you have not delivered that patient is not cured. So I've had problems or issues sometimes with women that are put on tablets. Their BPs are well controlled. We tell them, come back and we deliver you at 37 weeks if there's no preeclampsia, but they disappear, only to come back maybe when they are fitting, only to come back now when they are presenting the severe form of the disease. So the actual treatment of the disease is delivery. So if a patient now is found to have preeclampsia at term, that means at 37 weeks and above, we do not wait for them to get to their expected date of delivery. This is sometimes we have problems, sometimes with patients, where you tell them you are 37 weeks, we have preeclampsia, we need to deliver you. They say, doctor, can I not wait for my expected date of delivery? So we do not wait, because by waiting, you're going to be risking this woman presenting later on with severe disease. So the disease continues until the delivery has been effected. So if, for example, someone comes with the severest form that we sometimes see, that is eclampsia, where they are fitting, these ones should be inpatient. They need to be admitted. We need to give them antihypertensives to stabilize their blood pressures. We also give them anti-seizure medication called magnesium sulfate. We inject them that to lower the blood pressure partly, and also to prevent them from having further fits. And then we straight away plan delivery. This could be 28 weeks, this could be 32 weeks, this could be 37 weeks. In that case, the disease is actually life-threatening to this woman, and therefore their health care is of paramount importance. And therefore we take that drastic measure sometimes to deliver them prematurely and to risk having a smaller baby, a baby who may be admitted into a neonatal unit, or a baby who may go into special care baby unit for a prolonged period. But we know that at least would have saved that woman's life. So in general, this will be the outline of the management that we institute most of the time, depending on the gestational age, depending on the type of presentation that the woman says. Obesity puts you at risk of being of preeclampsia. So we've seen that actually by exercising, reducing your weight and obesity and managing the obesity well, there has been shown that there's a 40% decrease actually in the risk of getting preeclampsia. We also know that there's a wonderful drug called aspirin, but we have seen that it's actually a very wonderful drug that women can actually be put on that may actually reduce their risk of preeclampsia. We actually know that if you take it at the right dose, at the right time, starting at the right gestational age, you are able to reduce your risk of preeclampsia quite significantly. And so for this drug to work, you have to start it early in your pregnancy, before 16 weeks. So it becomes a challenge in our setting where most of our women are actually waiting up to 20 weeks, 28 weeks, even 30 weeks to actually come to the hospital. Once a woman is 20 weeks and above and the disease set in, it becomes very difficult. We have fallen behind the disease, and we are only going to be managing the complications, but not necessarily the underlying disease. So it becomes very difficult once preeclampsia is set in for you to be able to start to say, how do I prevent it? What else can I do? Also know that in those countries or in those places where patients are calcium deficient, giving them calcium may actually be one of the methods that can actually be used to prevent preeclampsia. But again, one of the things that one has to do, obviously, if you have chronic hypertension, managing your hypertension before you fall pregnant. If you are diabetic, managing the diabetes before you fall pregnant. If you have any endocrine disorder, managing it well, putting it under control, basically having what we call preconception care. That means being able to see your doctor or a specialist before you even get pregnant, so that those conditions can actually be managed well. So we know again that we can actually be able to predict with a quite significant accuracy which patient is going to develop preeclampsia. There are blood tests that can be done. There are scans that can actually be done. There's history that we can actually get from you that can actually detect with lots of accuracy which woman is going to get preeclampsia. And then those women can actually be given these therapies that I've spoken about. That advice to the nation is, personally, I feel that a lot of effort has actually gone into managing the disease, but not much effort has gone into actually predicting and preventing the disease. I have a feeling that we seem to be very comfortable in managing the complications of the disease. A woman comes in, she's eclamptic, she's fitting, we run around, we give antihypertensives, we run around, we give anti-seizure medications, we run around, we operate and we deliver them. But the question is, could you not have prevented, could you not have seen that this woman was at risk of developing preeclampsia? Could you not have predicted it? Could you not have prevented it? I actually feel that the cost that the nation is actually incurring in managing preeclampsia and its other effects is actually far much more than what we would do if we put up a very good preeclampsia prediction model, a preeclampsia prediction protocol that we can actually follow. Would save, I want to believe, a lot of money. A lot of women will be saved, a lot of babies will actually be saved if we started to do that, looking at prevention rather than managing, which is the current situation. But again, for that to happen, I know you need those women to come early, you need those women to book early. Remember, I spoke about starting aspirin, 16 weeks, but most of our women are not coming at that time. We need to improve in our surveillance, blood pressure. How much of blood pressure measurements are we actually doing in women who are booking? We also need to say how much of testing the urine are we doing. Some women can actually deliver without even had a BP done, maybe because of the remoteness of where they are having them, or where they are staying. So we need to be able to improve on that. So there's quite a lot of things that I believe that we may need to be able to do before we actually achieve this universal screening that I was talking about. So health education of our women, that they should not wait. Most women, I want to believe, they wait until they feel the baby to say that they are pregnant. But I've always said that a woman knows that they are pregnant by missing periods or missing their menses, and they know that they're not on contraception, and they know that they're sexually active. That on its own actually is pregnancy until proven otherwise. But most of our women, they wait maybe until they feel fetal movements, or they really don't see the need for them to be able to do that. Yes, I understand that our past models of looking at women were actually biased towards that. People used to believe that, why should I go to see a doctor at 8 weeks of pregnancy? Why should I see a doctor at 12 weeks? But we now know that once we start to see these women early on in pregnancy, there's a lot that we can actually begin to do. There's a lot that we can actually begin to, a lot of interventions that we can actually begin to do so that we prevent them from having many visits in later gestations. But we have seen that with our population, that has been the sort of the tendency. So there's a lot I want to believe that even as a nation, we need to educate ourselves on, even awareness. I'm very happy that we are making this recording in May. May is actually a Pre-eclampsia Awareness Month. On the 22nd of May, it will actually be World Pre-eclampsia Day. So